Well, good morning to those that have just arrived. I'm going to call the session to restart. It's my pleasure to introduce my colleague, Frances Valdez-Albini. Frances is our breast oncologist in Lennar Foundation Medical Center, and she will be addressing the updates on early stage breast cancer. Frances.
So thank you. There were many practice-changing trials presented at this year's meeting in the area of advanced breast cancer, and Dr. Krill will be addressing those. I'll be focusing on early-stage breast cancer, and I'll review some presentations on personalizing endocrine therapy, particularly in premenopausal patients. We also review 2 presentations on de-escalation of endocrine therapy. I'll review 3 trials on adjunctive therapies in the adjuvant setting, and finally comment on circulating tumor DNA in breast cancer. So when we're discussing personalizing endocrine therapy in early stage disease in our premenopausal group, we need to recognize that this is a higher risk group. So not only are younger patients presenting with a more aggressive subtype luminal B compared to patients above age 50, there are also doing worse. Their outcomes are worse as compared to those patients with luminal A cancers who present above age 50. So how can we improve outcomes for our premenopausal patients? We know that ovarian ablation works. Overall survival benefits for women less than age 50 with ovarian ablation was demonstrated in the early breast cancer trialist group with an absolute improvement of 12% in patients with node-positive disease in 15-year overall survival. We also know that tamoxifen works. This was demonstrated in NSABP-B14, which enrolled patients with ER-positive, node-negative tumors, and they were randomized to tamoxifen versus placebo. And in those patients less than age 50, 4-year invasive disease-free survival was improved by 12%. So what about adding tamoxifen to Garcialin in addition to chemotherapy? This was evaluated in ECOG 5188. It enrolled premenopausal patients with ER-positive, node-positive disease. All patients received chemotherapy. One arm received no further adjuvant therapy. One arm received Garcialin, and the third arm received Garcialin plus tamoxifen. And you can see that the 9-year disease-free and overall survival were improved with the combination endocrine therapy. And the benefit was more pronounced in those patients less than age 40. But the trial did not have an arm with tamoxifen alone. So would patients do just as well with tamoxifen, or is the combination of tamoxifen and ovarian suppression more effective? And this question was addressed in the SOFT and ASTRA trials. ECOG 3193 set out to address this question but closed early due to low accrual. I want to focus on the ASTRA trial. The 8-year follow-up was presented at this year's meeting. And ASTRA stands for Adding Ovarian Function Suppression to Tamoxifen in Young Women with Hormone-Sensitive Breast Cancer who remain premenopausal or resume menstruation after chemotherapy. This study enrolled premenopausal women less than or equal to age 45 after they had been treated with definitive surgery and chemotherapy, and those patients who retained ovarian function were then randomized to tamoxifen plus Garcialin versus tamoxifen alone. And the primary endpoint was disease-free survival, secondary endpoint overall survival, and additional secondary endpoints included recurrence-free interval, breast cancer-free interval, distant metastases-free interval, and local regional recurrence. And these are the results. After 8 years of follow-up, there was an absolute improvement of 5.2% in disease-free survival, favoring the use of ovarian function suppression. As of yet, no demonstrable benefit has been shown in overall survival, but this may require longer follow-up. And with respect to the secondary endpoints overall, there was an absolute improvement in 4% in recurrence-free interval, breast cancer-free interval, and distant metastases-free survival. So could we even do better by changing the tamoxifen or offering aromatase inhibitor, exemestane, instead of tamoxifen plus ovarian suppression? And this was addressed in text and soft studies. And the 12-year follow-up was presented at last year's San Antonio meeting. And after 12 years of follow-up, the overall survival was improved by 3.3%, favoring the use of aromatase inhibitor plus ovarian suppression versus tamoxifen plus ovarian suppression. So we have identified ideal endocrine agents for our patients. How can we optimize duration of adjuvant endocrine therapy? And this will apply to both premenopausal and postmenopausal women. So we know from the Oxford meta-analysis of 88 trials, which included almost 63,000 women, that more than 50% of distant recurrences occur after the first 5 years of follow-up, and that tumor size and nodal status remain major determinants of absolute risk of recurrence and death. So how can we improve these outcomes? These trials were designed to address the question of 10 years versus 5 years of endocrine therapy, and all three, the ATOM, ATLAS, and MA17, demonstrated improvement in invasive disease-free and overall survival with the extension of an endocrine therapy to 10 years, particularly in the node-positive patients. But those studies were utilizing tamoxifen up front, and most of our patients now are utilizing or we're offering aromatase inhibitor up front. So would we see the same benefit in patients who had previously received some time of aromatase inhibitor in the first 5 years? And this question was addressed in NSABP B42 and MA17R. And we see that in both of these studies, there is an improvement in invasive disease-free survival, however, partly explained by the prevention of contralateral breast cancer, and there was no difference in either of these studies in overall survival. So could we do just as well with somewhere between 5 and 10 years of adjuvant endocrine therapy? And this was looked at in the IDEAL and ABCSG16 trials, where they compared 10 years of endocrine therapy versus 7 to 8 years. And there was no difference in invasive disease-free or overall survival between the arms. And then I want to highlight the GIM4 study, that after 12 years of follow-up and including 2,000 women, there was a comparison between 7 to 8 years of therapy versus 5 of endocrine therapy, with the first 5 years including at least 2.5 years of aromatase inhibitor. And we can see that there was an improvement in invasive disease-free survival, an absolute improvement of 5%, and an improvement in overall survival of 4%, suggesting that 7 to 8 years of endocrine therapy, which includes 5 years of an aromatase inhibitor, can be considered the optimal duration for patients at intermediate risk of recurrence. And this table was provided by Dr. Pistilli, and it identifies that intermediate risk category and 0 and 1 as doing best, probably by offering these patients 7 to 8 years of adjuvant endocrine therapy. For those patients at higher risk and 2 and 3 disease, we should still probably recommend 10 years of endocrine therapy, most of it being aromatase inhibitor. And perhaps, though, for the earlier stage patients, more favorable tumors, T1A and B, and 0 or no negative T1Cs, grade 1, these are the patients that perhaps would do just as well with 5 years of therapy. How can we further personalize duration of adjuvant endocrine therapy? There are certain tools we can use. ASCO guidelines now include the CTS5 calculator, which is a web tool that can be used to calculate the estimated risk of late recurrence, which could assist in decisions about extended endocrine therapy. However, this has not been validated in premenopausal patients or in HER2-positive patients. We also have the BCI, or Breast Cancer Index, which is now part of NCCN and ASCO guidelines. This combines 2 gene expression signatures, molecular grade index, which evaluates or assesses tumor proliferation, and the HI ratio, which assesses estrogen signaling. It's been validated across several studies and in both pre- and postmenopausal patients. And again, we can utilize this, it's part of our guidelines, to better guide our recommendations regarding length of endocrine therapy. So are there patients that we can de-escalate our endocrine therapy for? And this is important because we know that our endocrine therapies significantly impact quality of life. So for the most part, we've been using genomic assays in early stage setting to guide our recommendations regarding adjuvant chemo, but we can also use such data to identify a lower risk group of patients. I want to point out Taylor X and MINDAC that identified a group of patients, approximately 1,600 women, that were considered low risk of distant recurrence, 1.5% at 9 years, and these were patients with no negative disease and recurrence scores less than 10. In MINDAC, a group of 2,745 patients were identified and considered to be low risk at distant recurrence with a rate of 2.4% at 5 years, and these were patients with no negative disease predominantly and low clinical and low genomic risks. Furthermore, MINDAC identified an ultra-low risk group of patients based on 8-year breast cancer events. This included about 1,000 patients, and they were categorized as that because their breast cancer-specific survival was 99.7% at 8 years, and their distant metastasis-free interval, 97.6% at 8 years. And their characteristics were older patients greater than age 50, 80% node-negative, and 96% of the patients had grade 1-2 disease. So these are the patients that perhaps we can consider de-escalating their endocrine therapy. This was a trial shown at ASCO that is currently open and enrolling. It's a Canadian trial, LALISE trial, and it stands for Luminal A, Limited Endocrine Adjuvant Systemic Therapy. It's enrolling these ultra-low risk group of patients. The Prosigna test has to be less than 40, and patients will all receive 2 years of endocrine therapy and then followed for 10 years, with the primary endpoint being 5-year breast cancer-free interval. Another study looked at de-escalation, but in terms of interrupting or less frequent dosing of the endocrine therapy. This is a randomized pre-surgical trial of alternative dosing of exemestane in postmenopausal women with early-stage ER-positive breast cancer. In this study, 180 postmenopausal patients with early-stage disease were randomized to receive exemestane daily, exemestane 25 milligrams 3 times a week, or exemestane weekly. Prior to surgery, baseline hormone levels were obtained and then repeated 4 to 6 weeks prior to surgery. So after 4 to 6 weeks of aromatase inhibitor therapy, we see the results that the percent change of circulating biomarkers, estradiol and estrone, were similar in the daily dosing versus every 3 week, and less so in the weekly dosing. And this again represents that data, percentage of participants with estradiol suppression, quite similar in the daily and 3 times a week dosing versus weekly. And the authors concluded that exemestane 3 times per week showed similar effects compared to exemestane daily in decreasing estradiol and estrone levels. There was a better effect, a more favorable impact on HDL levels, and that one can consider this regimen of 25 milligrams 3 times a week in prevention studies and perhaps in women who are intolerant to endocrine therapy daily in the adjuvant setting. I also want to comment on an area in recommending chemotherapy in a certain group of premenopausal patients where we may be able to de-escalate chemotherapy. In TAILOR-X, in our exponder, there was a group of premenopausal patients that seemed to benefit from chemotherapy in addition to endocrine therapy, those patients with node-negative disease with a recurrence score of 16 to 25 in TAILOR-X. And in our exponder, those patients with N1 disease with a recurrence score less than 25. These patients benefit from chemotherapy plus endocrine therapy different than those patients in the postmenopausal state. And the question remains, are these patients benefiting from chemotherapy because chemotherapy is leading to ovarian suppression, and could they do just as well if we offered all patients optimal endocrine therapy, which would include ovarian suppression plus aromatase inhibitor? The NRG has designed BR009 to address this question, hopefully will be open in the next year, and it's looking at these groups of women and randomizing them to receive chemotherapy plus optimal endocrine therapy with ovarian function suppression and aromatase inhibitor versus ovarian function suppression plus aromatase inhibitor without chemo. Now moving on to adjunctive therapies. ASCO recently updated their guidelines regarding bone strengtheners, and they recommended that adjuvant bisphosphonate therapy be discussed with all postmenopausal women, natural or therapy-induced, and that we should consider bisphosphonate therapy, oral or IV. However, the panel did not recommend the use of adjuvant denosumab. But I wonder if this will change based on a presentation, 8-year follow-up of ABCSG18 at this year's meeting. It was a prospective, randomized, placebo-controlled, double-blind, multi-center trial. It recruited over 3,400 postmenopausal women on aromatase inhibitor therapy, and they were randomized to denosumab, Q6 months for duration of endocrine therapy versus placebo. And early on, the study met its primary endpoint of decreasing risk of fracture, hazard ratio 0.5. And at this year's meeting, they updated 8-year follow-up on the other secondary endpoints, disease-free survival, bone metastases-free survival, and overall survival. And these are results in the intention to treat group. The disease-free survival was improved by about 5% with a p-value of 0.02. Bone metastases-free survival was also improved approximately 4% with a p-value of 0.05. And there was a trend towards improvement in overall survival, but not statistically significant. So the authors concluded that adjuvant denosumab is safe and markedly reduces treatment-induced clinical fractures even in the long term, and that disease-free, bone metastases-free, and overall survival are improved in this long-term analysis of ABCSG18, and that we need to consider adjuvant denosumab for routine clinical use in postmenopausal patients with hormone receptor-positive disease on AI treatment, and we'll see if ASCO guidelines are updated to include this. I do want to just briefly go over the adjuvant aspirin trial, ABC trial. It was a phase 3 randomized, double-blinded, placebo-controlled trial looking at aspirin in the adjuvant setting for our patients with breast cancer. Patients were randomized to 5 years of aspirin daily versus placebo. Over 3,000 women were enrolled. And here are the results presented at this year's meeting. There was no improvement in invasive disease-free survival or overall survival with the use of aspirin. In San Antonio last year, the adjuvant metformin study was presented, and in this study, patients in the adjuvant setting were randomized to receive metformin versus placebo for 5 years, and here are the results. The invasive disease-free survival and overall survival were not improved with the use of metformin, so currently we cannot recommend aspirin or metformin in the adjuvant setting if that is the only indication for our patients. So finally, to discuss the role of circulating tumor DNA in breast cancer, I do want to highlight the CHIRP study. Stands for Circulating Tumor DNA in Late Recurrence and High-Risk Hormone Receptor-Positive HER2-Negative Breast Cancer. Now, we know the risk of recurrence for hormone receptor-positive breast cancer persists for decades after diagnosis, and distant recurrences after treatment arise from residual disease. And we know that there's a benefit of treating residual disease because we know there's a benefit from adjuvant therapy that is well established. There have been several studies looking at minimal residual disease detection via ctDNA, and it is associated with high risk of breast cancer recurrence in the early adjuvant setting, as demonstrated by the orange line. This study looks at MRD detection via ctDNA in the late adjuvant setting. The study prospectively identified and consented patients with high-risk hormone receptor-positive breast cancer greater than or equal to 5 years after diagnosis without recurrence, and the study successfully enrolled 83 patients with successful whole exome sequencing and radar assay application. Patients were followed for recurrence as per standard of care, and plasma samples were collected every 6 to 12 months. And these are the results. 8 out of 83 patients had detectable ctDNA. 6 out of the 83 developed metastatic recurrence. All 6 patients had positive ctDNA prior to metastatic recurrence, and median lead time was approximately a year. 2 out of the 83 patients had positive ctDNA and have not had clinical recurrence at time of presentation. This just points out that the lead time varies between 7.8 up to 37.6 months. And this points out that serial sampling is important because only 2 out of the 6 patients who eventually had clinical relapse had their detectable ctDNA at the first blood sample. And although sample size is very small, we can see that the recurrence-free survival is much worse for patients who have detectable ctDNA as opposed to those who do not. So in summary, 10% of patients had detectable ctDNA greater than or equal to 5 years after diagnosis. 75% of patients with detectable ctDNA experienced metastatic recurrence as of last follow-up with median lead time of 1 year. This CHIRP study is an important first step toward understanding the role of ctDNA in this setting, and prospective clinical trials are underway and in planning to establish the clinical utility of ctDNA assays in this setting. I'd like to close by presenting this study that was presented at last year's San Antonio meeting. It shows the utility of ctDNA, in this case in the advanced setting. Patients with advanced hormone receptor-positive breast cancer were enrolled at the time of presentation and were treated per standard of care with aromatase inhibitor and palbociclib. And ctDNA, or specifically ESR mutation monitoring, was done at baseline, at 1 month, and every 2 months during treatment. And those patients moved on to step 2, who developed a rise in their ESR mutation, but no clinical recurrence. Those patients were randomized to continue on current therapy, which is our current standard of care. They would continue on the aromatase inhibitor plus palbociclib. And then the other half had an early switch in therapy of the aromatase inhibitor to fulvestrant and continued on palbociclib. So this was the median progression-free survival of those patients who remained on aromatase inhibitor and palbociclib at the time of the rise of ESR mutation. It was 5.7 months. And those patients who underwent early switch in therapy had a doubling of their median progression-free survival with the early switch in therapy, with an absolute improvement of 6.2 months in median progression-free survival. So this is the first clinical trial to demonstrate the clinical utility of ESR mutation monitoring. And upon monitoring, the median progression-free survival was doubled by the switch of AI to fulvestrant early on, and that this observed clinical benefit may justify the implementation of such a strategy as a valid option in routine care. And with that, Dr. Krill, I think, is coming on next. Thank you.
Dr. Elisa Krill will present now advances in breast cancer treatment for advanced breast cancer. Elisa.
Let's see, how's this work? Green button. Oh, okay. Hi, I'm Elisa Krill-Jackson. I'm a breast medical oncologist at This year's ASCO meeting for metastatic breast cancer was really exciting and also really disappointing, some of the studies. And I want to talk about a few main themes that came out of the ASCO meeting. The first is antibody-drug conjugates are here to stay, and they're revolutionizing therapy of many malignancies, but especially breast cancer. A second theme of the metastatic breast cancer trials was improvements in hormonal sensitivity and duration of response to hormonal therapy, and of course genomically directed therapies. And all of my slides are credited to the presenters at ASCO. So this first trial achieved a standing ovation in the plenary session of ASCO, and this was trastuzumab deruxtecan versus treatment of physician's choice in patients with HER2-low metastatic breast cancer. So HER2-low has not been previously defined, but these were patients who were not considered HER2 overexpressors, but had some HER2 on their tumors, so HER2 1 or 2 plus. Now, the background of this agent, TDXD, trastuzumab deruxtecan, it's a HER2-targeted antibody-drug conjugate, and it has been approved by the FDA for treatment of HER2-positive metastatic breast cancer. So in the DESTINY-Breast03 trial, it was investigated versus TDM1, which had been our standard antibody-drug conjugate for second-line metastatic breast cancer. And as you can see in the primary analysis, TDXD was far and away the winner. There was not only a progression-free survival advantage, but also an overall survival advantage in patients who got trastuzumab deruxtecan as their second-line therapy versus TDM1, and should be at this point considered the second-line therapy for patients with metastatic HER2-positive breast cancer. The biggest problem with TDXD has been interstitial lung disease, which you can see in other agents, but it was much more than expected in the original TDXD studies, which treated patients with much more advanced HER2-positive breast cancer, had more previous treatments. But you can see in this DESTINY-03 trial, there was no fatal ILD. So with better knowledge of it, better monitoring, and perhaps using it earlier before patients had been so heavily pretreated, we see much less ILD. This is just how TDXD works. TDXD, as opposed to TDM1, has 8 chemomolecules on it. TDM1 only has 3. It's a different agent. The TDXD binds to the HER2 receptor on a cell. It's internalized, and in the lysosome, the chemotherapy molecules are released, kill the cell, but also there's enough chemo to go out into the interstitium and to kill bystander cells who may have lower HER2 and not have taken up the antibody. So in this trial presented at the plenary session of ASCO, patients with HER2-low, 1 or 2 plus IHC, but FISH-negative cancers were randomized to either TDXD or treatment of physician's choice. These patients had all had at least 1 to 2 lines of prior chemotherapy. They had to be considered endocrine refractory. The physician's choice was our standard chemos, capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The primary endpoint was progression-free survival and secondary overall survival. And here are the results. Marked improvement in progression-free survival in all patients and hormonal responsive patients. So there was a almost 6-month improvement in progression-free survival in the HR-positive patients, 4 to 5 months in the entire group. And in the exploratory endpoints of progression-free survival and overall survival in the ER negative, so this is triple negative patients that happen to have HER2 1 or 2 plus, there was a marked improvement in progression-free survival from 3 to 8.5 months. I mean, 3 months just awful, as second-line therapy of triple-negative breast cancer with standard chemotherapy. But what was most remarkable is overall survival in triple-negative patients improved from 8 to 18 months, a 10-month improvement in overall survival with the use of TDXD as opposed to standard chemotherapy. This is practice changing. And you can see in subgroup analysis, every group responded to this therapy, and the overall response rate markedly improved, from 16% to 48% in hormone receptor positive, 11% to 48% in hormone receptor negative. This is a game changer in both ER positive and triple negative disease for us. And just because it's a pretty diagram and it's impressive, here's the waterfall plot. Safety was very good. There weren't very many serious, not more than you would expect, and ILD was low, although there was some fatal ILD on this study. So this established TDXD as the new standard of care in HER2 low metastatic breast cancer. I think this is going to require all of us to go back to our pathology reports because, I know that at the top of my note, I write the patient was HER2 negative. Well, HER2 negative is different now. It can't be HER2 negative. It has to be HER2 0, 1, or 2 plus. You need to know that. So it behooves us and all of our metastatic patients to go back to their original pathology report, do a new biopsy to see if they have some HER2 on their tumor because this is a game-changing medication for our patients. More antibody-drug conjugates. So this is the Tropics O2 trial, which was a phase 3 study of sacituzumab govitecan versus physician's choice. So same trial, but using sacituzumab govitecan, which is an antibody-drug conjugate which is already approved for triple-negative breast cancer. So this trial very similarly randomized patients with metastatic ER-positive, HER2-negative breast cancer to either sacituzumab govitecan or physician's choice. Again, similar agents, capecitabine, vinorelbine, gemcitabine, or eribulin. These patients had all had 1 to 2, but no more than 4 lines of metastatic chemotherapy. The demographics were very similar, and what I wanted to show you is the large group of patients who had liver metastases in these trials. So, 84% of patients had liver metastases. This was a very, very highly, very, very sick group of patients. These patients all had CDK4/6 inhibitor use, and the median number of prior chemotherapies was 3. So these were heavily pretreated patients. And again, you can see probably not as impressive as the Destiny 04 trial, but very impressive improvement in progression-free survival in the patients who got sacituzumab as opposed to standard chemotherapy. Median progression-free survival was 5.5 months versus 4 months. Again, how poorly we do in chemotherapy in our heavily pretreated patients. So amazingly enough, we're barely 2 weeks after ASCO, and the NCCN has updated their guidelines to include trastuzumab deruxtecan for all patients with HER2 1 or 2 plus cancer. and to update the guidelines for sacituzumab govitecan in patients with ER-positive metastatic breast cancer. So at this point in time, these are now standard of care, practice-changing trials. With the advent of updating the NCCN guidelines, we should all be able to get payers to pay for these agents. And I think it's time to go back and reevaluate our metastatic patients because we have 2 new drugs to offer them now. One more, just to show you where the field is in antibody-drug conjugates, is another study of patritumab deruxtecan. Again, the same deruxtecan backbone, but this is HER3-directed. HER3 is overexpressed in many types of cancers, including 30 to 50% of breast cancers. This is an ongoing phase 1-2 trial of this HER3 expressing antibody-drug conjugate. And what you can see here is across different subgroups of breast cancer, there's pretty good response rates. So overall response rate in ER-positive, HER2-negative disease, 30%, in triple-negative, 22%, in HER2-positive, 43%. And if you combine that, with the stable disease, even in triple-negative, you've got 70% clinical benefit rate, which is pretty amazing in triple-negative disease. And the duration of response is anywhere between 6 and 8 months, which is really quite good. So there's really good future ahead with these antibody-drug conjugates. Now I want to move on to some of our disappointing studies and hormonal therapy. So this is the update of the palbociclib plus letrozole study versus placebo plus letrozole, the Paloma 2 trial. This was very, very highly anticipated. We do know that in a different CDK4/6 inhibitor, ribociclib, it had shown in first-line therapy with an aromatase inhibitor overall survival advantage. All 3 CDK4/6 inhibitors do show a progression-free survival advantage, but we were awaiting overall survival advantage studies. So basically, Paloma 2 design randomized patients to letrozole in the first-line metastatic setting, plus or minus palbociclib. What I want to highlight here is if you look under disease-free interval, I don't know, do I have a pointer on this? Is there a pointer? No.
Oh, there's a green pointer.
There's a green pointer?
Yeah.
Oh, here we go. Oh, good. Okay, so this is what I want to highlight, is the disease-free interval less than 12 months from the end of adjuvant therapy to recurrence. So none of the other CDK4/6 inhibitor trials actually allowed this subgroup of patients on. So typically these patients would have been taking an AI, and less than 12 months later they relapsed and were put on again another AI, just as background to this trial. So if you look here, you can see the overall survival. There is no overall survival advantage to adding palbociclib to letrozole in this first-line setting in metastatic breast cancer first-line. Now, obviously, they were very disappointed by these results, so they tried to analyze why it didn't have an overall survival advantage, and there were about 20% of patients that actually dropped off study and were lost to follow-up, which is a huge number of patients lost to follow-up. And then there was also the large subgroup, about 20% of patients who had a disease-free interval of less than 12 months after their adjuvant therapy. If you analyze the Paloma 1, which was a similar earlier trial, and the Paloma 2 together, and you eliminate the patients that relapse less than 12 months, a lot of caveats there, you do see a survival advantage. So again, you see a 64-month versus 44-month average overall survival, which is similar to what the Mona Lisa trial showed with ribociclib. So this was a negative trial. If you use the caveat that this trial included that poor responsive subgroup of patients, you do see an overall survival advantage, but it is not statistically significant. It is uncertain whether palbociclib is an inferior drug or if they just set up the trial wrong. But I think for our savvy patients that ask about what drugs have shown overall survival advantage, this is something that we need to consider when we're prescribing them CDK4/6 inhibitor therapy. All right, so on a brighter note, we do have also new ways of making endocrine therapy last longer. This was a trial of fulvestrant plus capivasertib versus placebo in patients who had metastatic ER-positive breast cancer, the FACTION trial. So approximately 55% of patients with advanced endocrine receptor-positive tumors have mutations in the PI3K, AKT, and PTEN pathway. And this is a downstream regulator of estrogen receptor, NIS. And capivasertib is a potent and selective inhibitor of 3 AKT isoforms. So basically in this trial, patients were randomized to in second-line metastatic ER-positive breast cancer to fulvestrant alone or fulvestrant plus capivasertib. And what you can see here in the updated progression-free survival analysis is capivasertib did improve progression-free survival from 4.8 months to 10.3 months. So this is a positive trial. Now they looked at the patients who actually had mutations in the PI3K, AKT, PTEN pathway, and they did find that those patients were the ones who drove the benefit. So there was a marked improvement in prognosis in the patients who had mutations in that pathway. And if you looked at patients whose pathway was unaltered, there was no improvement in PFS. So we're going to be able, if this drug gets approved, to decide who would be the best patients for this trial. Again, interestingly enough, an overall survival advantage in the patients whose pathway were altered. You know, I remember 10, 15 years ago to see an overall survival advantage in metastatic breast cancer was extraordinarily rare. And now we're showing with genomically directed therapies that we're actually showing an overall survival advantage in well-selected patients. This drug, like alpelisib, which is a PI3K kinase inhibitor, which is already approved, has similar side effects: diarrhea, rash, hyperglycemia. Now, there are a lot of people who are using CDK4/6 inhibitors as second-line therapy after patients have already had them with first-line therapy without any data to that effect. This is the first phase 2 trial that has looked at this in a randomized fashion. So this is the MAINTAIN trial. This is a trial of patients who have relapsed on AI therapy, and they're randomized to either fulvestrant or exemestane with or without ribociclib, so another CDK4/6 inhibitor. Primary endpoint being progression-free survival. So what you can see here is there was some improvement in progression-free survival. I think the important thing, one of the striking things I found from this trial is just how poor our endocrine therapy alone is in second-line disease. The median progression-free survival was less than 3 months in patients switched from an AI to fulvestrant or exemestane. It doubled approximately when ribociclib was added. Overall response rate increased with the addition of ribociclib to hormonal therapy alone from 15% to 20%. Clinical benefit rate improved. And in an exploratory analysis in patients with ESR1 mutations, you can see that all of the benefit of adding the CDK4/6 inhibitor was in patients who had a wild-type ESR1 mutation. There was no benefit in patients who did not have an ESR1 mutation. There was no benefit in patients who were ESR1 mutant. So in summary, in the fulvestrant subgroup, there was a 40% risk reduction of progression or death when ribociclib was added, and fulvestrant alone had a very, very poor progression-free survival alone. So this is the first trial to show a benefit of a second-line CDK4/6 inhibitor after a first line with switching of the endocrine therapy. But we do not think at this point this is practice changing, and there are other partner drugs that we routinely use in this group of patients, such as alpelisib if they have a PIK3CA mutation, or everolimus, which may be superior. And phase 3 trials are currently being done to see if this is a true benefit. I wanted to show this from the poster session at ASCO. In our patients who are getting CDK4/6 inhibitors, we often have to lower the dose because of toxicity, usually neutropenia. Patients worry that they're getting less of an effect. This study basically showed that in patients who had a lower dose of ribociclib, there was no difference in prognosis. Their progression-free survival was exactly the same. So I think with this trial, we can reassure our patients that they will not have a decrease in their prognosis. I'm running a little over, but I'd like to get to the last few if everybody can hang in there. Okay, so this was an important trial. This was a stereotactic body radiotherapy trial of patients with oligometastatic breast cancer. We spend a lot of time in our tumor boards in patients with oligometastatic disease saying, should we treat the mets? Should we ablate the mets? This trial looked in a randomized fashion ablating oligometastatic metastases. So, we know that oligometastatic disease does have a better prognosis than widely metastatic disease, and that it is certainly possible to ablate these metastases with surgery or radiation. We know that in the SABRE-COMET trial, which looked at all different tumor types, there was a marked improvement in prognosis in patients who had ablation of their metastases, although there was significant grade 5 toxicity. But the data is lacking in breast cancer. So the NRG-BR002 randomized patients with 1 to 4 metastases to either symptom-directed therapy, so only radiation if they had a symptom, and good systemic therapy versus the same good systemic therapy plus ablation of their metastases. You can see here that the majority of patients, 80% of patients, were ER-positive, HER2-negative. The HER2-positive subgroup was quite small, only 12%. Triple-negative subgroup, only 8%. And what you can see here is there's no benefit in progression-free survival in this group of patients. So quite a disappointing trial. In fact, the patients who got ablation numerically did worse than the patients who did not get ablation. So why would this be different than in all malignancies? Well, it might be that our systemic therapy is better in breast cancer, and ablation therapy is salvaging some patients with other types of malignancies that don't have as good systemic therapy. But we don't know the answer to that, but I think this, along with the trial that showed that controlling the primary in patients with metastatic disease did not improve prognosis, should ring the death knell for aggressive treatment of oligometastatic disease, with the caveat that I think this only really probably applies to the ER-positive subgroup. I think in the in the HER2-positive subgroup, we do see patients that have long-term disease-free survival, and I don't think that that question is really answered for the HER2-positive subgroup. Again, overall survival was not improved in this group of patients. So this trial was going to go on to a phase 3 portion and is no longer going to go on to that portion. And for my last slide, yes, I'm almost done. I just wanted to mention three medicines that hopefully will be approved in the near future for breast cancer. The first is lasofoxifene, which is a third-generation SERM in the ELAINE-2 trial, combined with abemaciclib in patients with ESR1 mutations and prior hormonal therapy. There was a clinical benefit rate of 62% and a progression-free survival rate of 13.9 months, which is really just phenomenal for a tamoxifen-like drug used in third-line therapy. Imlunestrant, which is an oral SERD, which we've been waiting for, an oral SERD to get approved for our patient. There was a clinical benefit rate of 40%, although a true response rate of only 8%, regardless of ESR1 mutation. And we know that PARP inhibitors work for BRCA mutated tumors, but can we make tumors act like they're BRCA mutated? So a BET inhibitor was added to a PARP inhibitor in triple-negative breast cancers that did not have BRCA mutations, and they saw an overall response rate of 22% and a clinical benefit rate of 35%. So I think the future is really very bright for metastatic breast cancer. We're making a lot of strides, and it's pretty exciting. So current practice changing, TDXD, yes. I wrote this before the NCCN guidelines came out. Sacituzumab govitecan is not probably, it's yes. CDK4/6 inhibitor after progression on a CDK4/6 inhibitor, not yet. Ablation of oligometastatic disease, no. And new drugs on the horizon when approved, definitely. Thank you.
Francis. I was going to just say, let me change a little bit the agenda. No, we're going to do this now. Yeah, Francis, you want to come? Let me delay a little bit your lecture, Jose, because there's a lot of information. Was that? Oh yeah. Oh, good. We're going to move a little bit the questions and answers. We're going to have a Q&A for Dr. Lutzky that comes afterwards. But let me open the floor for questions for breast cancer. Anybody? Peter is coming. Peter is coming to. Okay.
So, very nice presentation. So, Dr. Curl, the HER2 low, what proportion of breast cancer? I mean, the HER2 positive, I think it's in 20-25% normally for metastatic breast cancer, right? Do we have an idea of how many more patients would be eligible for the TDXD that were not before?
I think you're talking probably 50% of breast cancer. I'm not sure the exact numbers, but in the triple negative population, it's probably 30 to 40% that are HER2 1 or 2 plus, and in the ER positive, it's probably closer to 50% that are HER2 1 or 2 plus. So it's a substantial proportion of patients that are going to be able to benefit from this.
I had the same question in my mind. The question was really who is not. HER2 1 plus. Essentially,
there's a lot that are HER2 0.
Yeah.
We don't know. I mean, maybe they will benefit as well. And I think it behooves us, given the marked improvement in progression-free and overall survival, to maybe rebiopsy our patients, or there are some genomic tests now that can look at circulating tumor cells and detect HER2 on the surface of these circulating tumor cells. So I think it really behooves us to look for HER2 positivity now in our patients, given that this is markedly more effective than our standard chemotherapies.
Emeka?
Yeah. So in a patient, in whom you start olaparib or talazoparib, and then fails that treatment, what would be the next, port of call for such a patient? Would it be immunotherapy or platinum?
I'm
sorry. These patients with a BRCA2 mutation,
a patient with a BRCA mutation?
BRCA2, CHEK2, that you start olaparib, for instance, and they fail olaparib, they progress on olaparib.
So, I think it depends. Unfortunately, the BRCA group of patients is pretty small. The PARP inhibitors appear to really only work for patients who have germline or somatic BRCA mutations and maybe germline ATM mutations. So we really don't have that much targeted therapy for that. So those patients will often get a PARP either first or second line, and then third line is just standard chemotherapy. And now we have 2 more drugs. We have I'd probably prioritize TDXD given its marked improvement and its great safety profile. I find sacituzumab govitecan, the data was less exciting, and I find that a slightly more toxic drug. Do you find it?
It just depends on the biomarkers too.
Yeah.
Is it hormone receptor positive?
I see.
Yeah.
Okay.
So there's a lot of options.
No, the reason I ask, I'm not a breast oncologist, as you know, but the reason I ask this question is I have a head and neck, believe it or not, malignant patient who had a CHEK2 and BRCA2 mutation. so who progressed on olaparib that I put the patient on. So I'm here wondering, based on a scan that I did yesterday, so I'm here wondering what will be the next, will this patient, because of they have difficulty with, DNA repair system, will they respond to checkpoint inhibitors or platinum? So I'm just thinking out loud. So I figure since you guys deal with PARP inhibitors, that this would be the best forum to bring this problem.
I think, the breast cancer has been left a little out of the immunotherapy party, except for triple-negative disease in the neoadjuvant setting and triple-negative PD-L1 positive. In the metastatic setting, there isn't a great role at this point in time for immunotherapy in breast cancer, unfortunately. Luckily, we have hormonal therapy for a large subgroup of our patients.
Francis, you presented data on actually 3 non-oncology drugs or non-anti-neoplastic drugs that are being tried to be used to improve survival. Aspirin and metformin, that was negative. As a hematologist, I'm glad that aspirin was found to be negative. We want to claim exclusive use of that. No, on top of that, there's a lot of iron deficiency with that. But I'm intrigued by the use of Xgeva, denosumab. Oh, look at that. There is a question about that from online too. And let me go back. I was going to ask the same question in a different way. Is a major problem with denosumab is a marked loss of bone density after discontinuing the medication. If it's used in the adjuvant setting, how do you deal with the rapid loss in bone density after stopping it? And my part of the question is this changing your practice? Are you putting everybody on an AI now on denosumab, not just because of the bone health, but because of the survival that was observed?
Yeah, so I think now we may have this option as well. It's hard to decide, and I don't think they'll have that study comparing bisphosphonate therapy to the denosumab. I think we need to consider it. The presenter of that study, Dr. Nant, did comment on overall, in general, the bone event rates were still better with the use of denosumab. That kind of conception that we're going to have a significant decline in bone density doesn't pan out or correlate then with long-term bone fracture issues, and that still the overall benefit remains. So yeah, no, I think we have to consider the denosumab in addition to bisphosphonate and discuss patients. So I expect that my answer would be yes, that perhaps the ASCO guidelines will be updated to include denosumab, yes, for those other benefits in addition to fracture.
Okay, and then there is, this is going to be the last question from the online audience. The benefit, this is the way it's expressed, the benefit of ablation of oligometastasis may be to continue current systemic therapy, not necessarily to increase progression-free survival. Did the study address this? I think that they're trying to ask if, we manage oligometastasis with stereotactic radiosurgery, and that allows you to have more leeway for systemic therapy.
In our group, we'll often patients who have oligo progression. If they have progression at just one site of metastasis, sometimes we will ablate that site of metastasis and continue the therapy that they've been on. But I think we're clearly doing that without data. I think at least in breast cancer, at least in ER-positive breast cancer, ER-positive HER2-negative breast cancer, we don't find a PFS or overall survival advantage from ablating metastases, and I don't think we should be doing this routinely in clinical practice, which I think is going to be a hard discussion with some of our patients who present. There's always anecdotal patients who you've ablated one metastasis and they've done well, but in this particular trial, they even looked at patients who had one metastasis that was ablated, and they frankly did numerically a little bit worse than the patients who had 3 or 4 metastases. So I don't think this should be something that is done routinely, at least not with the expectation that we're going to be improving their prognosis.
Well, thank you very much. Let me introduce Dr. Jose Lutzky. He is a lead for cutaneous malignancies. He's going to be presenting advances in cutaneous malignancies and melanoma.
Hi, good afternoon, everyone. I'm Jose Lutzky. I'm the Director of Cutaneous Oncology at Sylvester. My job here today is to give you updates in melanoma over the last year, primarily presentations from AACR and ASCO. So these are some of the areas I'm going to touch on. There was a lot of neoadjuvant therapy presented at ASCO this year. We're going to talk about the one adjuvant trial, and then we're going to move on to advanced disease, and we're going to try to touch on all of those issues, hopefully to stay within the 20 minutes or so that I'm allotted. So starting with adjuvant therapy, at ASCO this year, there was an update on this trial, Keynote 716, which is a trial in which patients that had stage 2B and 2C melanoma were either given pembrolizumab or observation or placebo for a year. These patients then, upon recurrence, they were unblinded, and if they had not received pembrolizumab, they had the option to cross over to the pembrolizumab arm. This initial data was presented last year, and it did show that the primary endpoint of the study, which was relapse-free survival, was reached, and in fact, it led to the approval of pembrolizumab as an adjuvant treatment for these patients. So this year we have some additional data and additional follow-up. The first thing was a confirmation that indeed relapse-free survival is superior in the group that gets pembrolizumab. We have 24-month data now with a difference of almost 10% between the treated group and the non-treated group. And this is the third interim analysis now. And this is new now. This is distant metastasis-free survival. This is the new data. It's the secondary endpoint, and it did reach statistical significance, as you can see there, a 0.0029 p-value, a difference of between 12.9% in the pembro group versus 19.4% in the placebo group. What's interesting here also, I'm not showing that data, that it seemed to change the pattern of recurrence. The decrease in recurrences was more towards metastatic disease, particularly lung recurrence, rather than local recurrences. So the question is this the new standard of care for all patients? It's certainly a new standard of care. You know, in oncology, there's no standard of care for all patients. We always have to individualize this. There are certainly a number of patients that I would not consider doing this, and again, a number of patients that I would, and it really needs to be discussed with the patient, take into consideration comorbid conditions, age, and a number of other factors. So moving on to neoadjuvant therapy. So the Prado trial was conceived based on a previous trial, European trial called the Opsin trial. And in that trial, they tested different types of neoadjuvant immunotherapy. One arm was ipi-nivo standard dose. The other arm was ipi-nivo with a lower dose of ipi. And the third arm was a sequential treatment of ipi followed by nivo. And from that trial, they found that the best arm in terms of response and toxicity was the ipi-1 nivo 3 arm. And this is what was used in this trial. So these are patients that have a stage 3B, 3C disease, that have measurable disease. So these patients had an index node determined because that node is going to be the one that's going to be biopsied after neoadjuvant immunotherapy. They got treated with ipi-nivo for 2 cycles, and then the index node was biopsied or resected. And depending on the findings on the index node, different things were done. So I have to preface that by saying that there is data showing that the status of the index node does in fact predict what you're going to find in the rest of the nodal basin. So if pathologic CR or a near pathologic CR was found. No additional lymphadenectomy was done. Patients were followed with imaging studies. If there was a partial pathologic response, as defined there, between 10 and 50% of viable cells, greater than 10 to 50% of viable cells in the node. They did do the nodal dissection, and again, no additional treatment was done, and patients were followed with scans. If there was no pathologic response, there was nodal dissection followed by adjuvant therapy, nivolumab, or if patients were BRAF mutated, some of those patients also got targeted therapy. So on the right, you see the outcome, the pathological response rate, which was amazing, 50% complete pathological response, plus another 12% of near complete pathological response, plus another 11% of partial pathological response. And obviously, because a number of these patients did not get a lymphadenectomy, the surgical morbidity was markedly reduced. So here is some of the outcome data. We have follow-up up to 24 months now, and I'm sorry that this is it is big enough. But on the left upper portion of the slide, you see relapse-free survival and distant metastasis-free survival for the whole group. And it actually looks really good for this group of patients, just from the get-go, looking at the whole cohort. And then on the right, you see the relapse-free survival and distant metastasis-free survival for the different groups that were treated, as I showed you earlier. The green line is the patients that have complete pathologic response, and they did amazingly well. Distant metastasis-free survival was almost 100% in that group out to 2 years. The yellow line is actually the group that had partial pathologic response. Remember, that group had lymphadenectomy, but they were not given adjuvant therapy. And the red line is the group that did not have a pathologic response, but after lymphadenectomy, they were giving adjuvant therapy. So actually, the partial response group did not do as well as expected, as seen in previous trials. But I believe that really sets a great precedent for the use of neoadjuvant therapy in these patients. Obviously, we're not quite ready for prime time. Let me show you another neoadjuvant treatment. This one is in desmoplastic melanoma, which is a rare type of melanoma, often amelanotic, but often you find more disease than you expect when you go in and try to resect this. There's usually residual disease, and this tends to be in areas that are cosmetically sensitive. So there's also data in advanced disease with desmoplastic melanoma. There's a very high response rate with a single agent immunotherapy, 70%. And based on that, the SWOG study was done in which patients that had resectable desmoplastic melanoma, residual disease probe biopsy, previously untreated, received pembrolizumab for 3 cycles. And then if the disease was resectable, then they had surgery. Otherwise, they got additional immunotherapy. But the bottom line is this: there was a 55% rate of complete pathological response in these patients. And what is interesting also, if you look at the clinical responses, they were 46%. So it's not unusual, and we're seeing that more and more in neoadjuvant treatments, and I don't think that's restricted to melanoma, that the clinical and radiological responses actually underestimate the degree of pathological responses. So that's what we're seeing in this. And I think the basic issue here is that early use of pembrolizumab in patients with locally advanced desmoplastic melanoma is supported by this trial. As I said, this tends to be in cosmetically sensitive areas, so this could be practice changing for those patients. And this is the other neoadjuvant trial that was presented. This is looking at adding targeted therapy to immunotherapy in the neoadjuvant setting. And so there are 3 cohorts here. The first cohort was pembrolizumab alone. The second cohort was sequential pembrolizumab, and this is for patients. That are BRAF mutated, so they receive BRAF and MEK inhibitors followed by pembro, and the third cohort received all 3 concurrently. Patients were treated, had surgery after 3 weeks with complete nodal dissection, and everyone received additional adjuvant pembrolizumab. The primary endpoint here was the pathological response rate at 6 weeks, and the pathological response rate here, 6 weeks, was 50% in the group that received concurrent therapy. So the concurrent therapy group was actually superior to the other 2 groups. That's particularly not dissimilar from the data that I show you from Prado with immunotherapy alone. So to me, it's really unclear whether this is an improvement over the combined immunotherapy group. We're only going to define that with additional randomized trials. So is neoadjuvant therapy the new standard of care for all patients with locally advanced resectable disease? I don't think it's the standard of care. I think we discuss these patients on tumor boards all the time. And I think for some of these patients, it is the appropriate thing to do. I think we're going to need to look at the results of these randomized trials before we can make this the standard of care for all patients. SWAB 1801 randomizes patients to pembro or no pembro, neoadjuvantly, followed by adjuvant pembro after resection. And this trial actually just completed accrual recently, so it's closed, and we should hopefully have some data pretty soon. The ECOG trial 6194, we have this open at Sylvester, and this is finally open, and this is currently the one neoadjuvant trial that we have. So patients here are randomized to receive in the neoadjuvant setting pembro alone or CMP-001, which is a toll-like receptor 9 agonist in combination with pembro. So these patients have to have injectable lesions because this drug is given intratumorally, and the idea here is to turn a cold tumor into a hot tumor and theoretically more responsive to immunotherapy. So patients have a definitive surgery and they get additional pembro afterwards, and we're looking forward to the results of that trial. That will take a while. So moving on to advanced disease, so I just wanted to mention the update on 067, which is the trial that compare the first-line treatment of patients with metastatic disease with ipilimumab or nivolumab or ipi plus nivo. And I'm showing you only the melanoma-specific survival here, and we are at 7.5 years. So that's a long time for melanoma, and we have 55% of patients in the ipi-nivo arm alive at that time, and 47% of the nivo group, and both of those are clearly superior to the ipilimumab alone arm. Remember that this trial was not powered to show a difference between the ipi-nivo arm and the nivo arm, although there is a substantial numerical difference that you can see there. So there were also two abstracts that were presented, one in the oral session about further updates of the combination of nivolumab and relatlimab. As you may remember, the combination of nivo-rela, which is a LAG-3 inhibitor, was presented last year, And it was a study comparing nivolumab alone versus nivolumab plus relatlimab in patients first-line metastatic disease. So this is the schema of that trial. The patients were compared randomized 1-to-1 to Nivo Rela versus Nivo, and the primary endpoint of that trial was progression-free survival. And this was shown last year and actually led to the approval of this combination for patients as a first-line treatment. In fact, at any line treatment, the FDA actually allows that. And this year we had some updates, and this slide, basically condenses all these updates. The progression-free survival continues to be superior, essentially twice the progression-free survival, the group that received Nivo alone. And we have two new pieces of data here. One is the response rate, which is seen on the bottom. It's about 10% superior for the Nivo-Rela group compared to Nivo, and that is significant. We have also early overall survival data that has not reached a significance, but appears numerically superior. So I'm not showing you all the forest plots that were shown, but what I can tell you is that in terms of progression-free survival, and overall response rate, the combination was superior to Nivo across all the subgroups and across all the biomarkers that were checked, BRAF, PD-L1, and LAG-3. Safety profile, there were no surprises there. Nivo-Rela is a bit more toxic than nivolumab, but less toxic than Ipi-Nivo. So what do? I mean, we have a lot of new drugs and new combinations and different settings. And when do we use PD-1 monotherapy? What kind of patients? So there is really no consensus, but I think there is a general feeling that in patients that have poor performance status or borderline performance status, patients that have autoimmunity, because you really don't want to exacerbate autoimmunity, transplant patients, which we try not to use immunotherapy, but when we have to, we probably may want to use monotherapy. Patients with low volume disease, and that there is some data that does show that patients with low volume disease may respond quite well to that. But on the other hand, when you look at the recent Nivo-Rela data in the subgroup that had low volume disease, they did remarkably better than Nivo alone. So that may not be a good reason to do it. Desmoplastic melanoma, as I showed you, has excellent responses to monotherapy. So that group may still be appropriate to use that. Patients that have a poor support system, you really don't want to give them toxic immunotherapy if they're not going to be able to come to their appointments. They don't have anybody to bring them to their appointments. And then at this meeting and other meetings, there has been a group that has been defined as a high responder group, which are tumors that have a high interferon gamma signature, a lot of infiltration by CD8 T cells, and PD-L1, perhaps. So maybe in those groups, we can still use monotherapy. But for combined therapy, we certainly want to use that in patients that have high LDH, PD-L1 negative patients. We don't really have, we have very good data with combined immunotherapy in brain metastasis, which is superior to the data with single agent. We don't have a lot of data with mucosal and acro with the anti-CTLA-4 and LAG-3 combination, but a PD-1 and CTLA-4 combination, it appears superior to single agent therapy. The BRAF mutated group of patients, now we do want to use combined immunotherapy first. And I'll show you the data from the DREAMseq trial, which was a very important trial that defined that. And these patients have to be in good performance status, and if they're in excellent performance status, regardless of all the other factors, we may actually want to use combination therapy. So how do we choose between Nivo-EP or Nivo-Rela? So personally, I think we need a lot more data on the Nivo-Rela combination to make that determination, particularly survival data. And we don't have a lot of data of the new combination in brain mets, in acro, mucosal, or high LDA patients, so we want to keep an eye on that. What do we do with patients that are treated with Ipi-Nivo and relapse? Should we use Nivo-Rela? There's little data with that. There's all the phase 1 data from Nivo-Rela that show their response rates were between 10 and 15%. Not great. What about the other way around? If we start patients on Nivo-Rela and we salvage them with Ipi-Nivo, there's even less data there. And Menzies has recently published some retrospective data, and the numbers there are also 10 to 15%. Not great. How about triplets? Triplets, at least one triplet has been approved for use in patients with metastatic melanoma. I think triplets are difficult. They're certainly more toxic than targeted therapy or immunotherapy. Their progression-free survival advantage is not great. And now with the data showing that Ipi-Nivo is certainly better than targeted therapy, we really need a trial to show that where triplets fit there. I personally don't use a lot of triplets, but I'm open to results of new trials. So this is the DREAMseq trial, and for the longest time, I remember being asked, we have a patient who's BRAF mutated. How do we treat him? Should we use targeted therapy? Should we use immunotherapy first? And this was really difficult to accrue. Dr. Mike Atkins, who pioneered this trial, really pushed for this for years. And finally, we have data that's really important. So BRAF mutated patients were randomized to receive Ipi-Nivo, and if and when they recurred, they were given targeted therapy. And the second arm was the opposite. Patients got targeted therapy first, and upon progression, they got Ipi-Nivo. And the data couldn't be more clear. You see overall survival on the left, and when this was first reported late last year, there was an absolute 20% better survival in the group that received Ipi-Nivo first, as compared to the group that received targeted therapy. And on the on the year 3 update, which was presented at this year at ASCO, the difference was even bigger, was more like 24% or 25%. So I don't think there's much doubt there. Duration of response that you see on the right was also superior. So the bottom line here is Nivo followed by Ipi, I guess Nipi, and if necessary, followed by BRAF/MEK inhibitors, should be preferred treatment sequence for the majority of patients with BRAF mutant melanoma. There are exceptions, patients that present, for example, with extensive brain metastases and a lot of edema. You probably want to give them targeted therapy first because you will likely produce significant edema and tragedy if you give them immunotherapy first. But for the most part, these patients should be treated with immunotherapy combinations. Very quickly, now that I see that I'm getting towards my time limit here, the other question that we've had, so we treat patients with nivolumab and they recur. So what should we give them next? The question is, do we give them ipilimumab as a single agent, or do we give them ipilimumab and Nivo? So there is some data. There is a retrospective data from Australia that suggested that Ipi-Nivo was superior. There is also a trial that was recently published, a single-arm trial with Ipi and pembrolizumab showing a 29% response rate for that combination with toxicity that was very acceptable. But this is the only randomized trial that we have, and these patients here, upon recurrence from single-agent PD-1 inhibitors, were either given IPI at the standard dose of 3 milligrams per kilo or IPI-NIVO at the standard doses also. It's amazing to me, though, that this being a SWOG trial, there were only 92 patients. This was difficult to accrue because everybody thought they knew what they were doing. And they probably did. When you look at the results, there was a 9% response rate for AP alone and 28% response for the combination. And the primary endpoint of this trial was progression-free survival, which was indeed superior for the IPI-NIVO arm. The overall survival was not statistically different because there was probably a lot of additional treatments following progression. Anyway, despite the small size of the trial, it did achieve significance. So I would say that the standard of care now for these patients is combination immunotherapy rather than single-agent IPI. So how about brain metastases? There was a trial looking at patients with brain metastases that were not symptomatic and had relatively small brain metastases that showed a very high response rate in the brain without additional intervention as first line. And you can see, and that's the panel on the left that you see. And during that trial, towards the end of the trial, another cohort was added. There were patients that had symptomatic brain metastases. And as you can see that on the right, they didn't do very well. So unclear what to do for those patients. And this trial is for those patients, actually. So patients that were BRAF wild type were given atezolizumab and cobimetinib, which is a MEK inhibitor. Remember, the reason that we give MEK inhibitors in these patients because MEK inhibitors have been shown to promote CD8 T cell infiltration into the tumor, theoretically making them more responsive to immunotherapy. And cohort 2 was a MEK inhibitor, a BRAF inhibitor, and the atezolizumab. So I just want to show you one slide here from this. And if you look on the right, the asymptomatic patients that were similar to the patients that I showed you before from the other trial with IPI-NIVO did about the same, maybe actually a little bit worse, with response rates of 46%. But the symptomatic patients that did very poorly in the other trial actually did relatively well here. And half of those symptomatic patients on steroids were able to taper or discontinue the steroids. And again, I think this is the same thing that I mentioned before, that for some patients that have significant brain metastasis, targeted therapy is probably very useful. There are a couple of randomized trials that are still looking at this issue. The one we're doing at Sylvester is SWOG S2000, in which patients that have BRAF mutated melanoma are randomized to receive targeted therapy plus nivolumab versus IPI-NIVO, which is currently the standard of care. Transplant patients are a problem, and this is my last set of slides, because they have a higher frequency of developing not only melanoma, but all kinds of cutaneous malignancies, and these tend to be aggressive because they have immunosuppressed, they are immunosuppressed. Using immunotherapy on these patients has been shown to many times lead to graft loss because of a rejection. So this trial looked at a combination of tacrolimus and prednisone followed by nivolumab alone. Those patients that responded to nivolumab were then continued on nivolumab. Patients that did not were switched to IPI-NIVO. And this is sort of the data, what is amazing is that nobody responded to nivolumab alone in this setting. That makes me wonder whether the tacrolimus and prednisone may have had a role in that. And then the patients that were switched to ipi-nivo, there were 2 CRs, but you should also look at the high incidence of allograft loss. There were 3 patients that lost their allograft in this small trial. So the conclusion really is that still need to have a lot of work to do here. And I want to say that we are doing a trial at Sylvester for that group of patients, and we're looking at an oncolytic virus in patients that have transplant patients. These patients cannot have metastatic disease, but if they have advanced localized disease, they are candidates for this trial. And there was a lot more that happened during ASCO in this area, but I think I've exceeded my time, and I'll stop here. Thank you.
Thank you very much. Elisa, you have a question?
I do have a question. So the first 2 trials you presented, one was an adjuvant trial with, I think, a year of pembro, and then there was the Prado trial, which in patients, it looked like to me, and I wanted to be clear, they got like 2 cycles of neoadjuvant immunotherapy, combined immunotherapy, and if they had a CR or near CR in the node, that's all they got is adjuvant therapy and still had a marked.
Yes.
So
those patients that had complete pathological responses did not get additional adjuvant therapy.
So, I mean, that's so much less therapy than a year of pembro for these patients, you know, economically and side effect-wise and time-wise. Obviously, it was a small phase 2 trial, I guess, but...
Well, there were 100 patients. There are 99 patients. So
should that be the standard of care, as it minimizes their therapy? For 2 months of therapy, 50% of the patients got away with just two cycles of therapy as opposed to a full year of pembrolizumab. So are we over-treating the other patients? And then the second question is the patients who didn't respond, yet we kept them on the same therapy for a whole year, which doesn't make a lot of sense. To keep them on the same therapy for a year that they didn't respond to up front, and are people looking at, you know, designing a different adjuvant therapy for those patients who didn't respond?
Well, let me start with your second question first. I mean, they may not have received enough immunotherapy, and maybe that's why additional adjuvant therapy could have helped there. And the patients that were BRAF mutated are certainly not seeing BRAF MEK inhibitors, and we know that really works in the adjuvant setting as well. So in terms of the group of patients that did really well, I think you have to consider that ipi-nivo has toxicity, has more toxicity than monotherapy. But I agree that if someone has really excellent performance status and has locally advanced disease that is resectable, I think that should be a consideration. And as I said, even though it's not considered standard of care because there's no randomized data, we discuss this practically every single tumor board. And most of the time we end up recommending a neoadjuvant treatment for these patients.
And in that trial, the IPI dose was pretty low, right?
It was IPI 1, NIVO 3.
But that's a pretty low dose of IPI, right? There was a previous
trial that suggested that dose achieved the same degree of complete pathologic response with lower toxicity than the standard IPI-NIVO. Yeah.
Thank you.
Any other questions? Peter?
I have a question about their LAG-3 inhibitors. So, do you see the same rate of immune-related adverse events? And if you have immune-related adverse events with a PD-1 LAG-3 combo, would you expect to have the same thing if you challenge them with a CTLA-4 drug or vice versa?
I'm sorry, Peter.
The question is regarding immune-related adverse events with the LAG-3 inhibitor, and whether that could also overlap with the CTLA-4, for example. So if you give a PD-1 LAG-3 combo and you have to stop because of immune-related adverse event, whether if you challenge that patient with a CTLA-4 drug, would you expect them to have the same reaction?
There is some data on that, and for a long time we never really re-challenged patients, but there's data that suggests not everybody recurs with the same adverse event profile, and I think a good number is about 50%, and that really depends on the type of immune-related adverse event that you have. But you can expect for the most serious ones, like severe colitis or pneumonitis, there's about a 50% chance that those will recur. Now, with RELA, if you treat someone with ipi-nivo and then you treat them with nivo-RELA, I mean, I don't know what that number would be, but that's basically the only data we have.
I'm going to put this question from online as the last question, and also combine it with a question of mine. It has to do with BRAF-mutated melanoma. The question is, what is better first line for asymptomatic BRAF-mutated brain mets, BRAF-MEK inhibitor or ipi-nivo? And my part of the question has to do with early
asymptomatic?
It doesn't say.
Oh, okay.
So, and extending it to early disease, do the extended to the metastatic disease data change your adjuvant treatment for BRAF mutated melanomas?
Yeah. So in patients that have brain metastasis, as I showed you, I think there is a lot of very good data with ipi-nivo upfront. But for a subset of patients, those patients where they had disease that was less than 1 centimeter in size, they could not have a lot of edema, they could not have symptoms, they should not be on steroids. Those patients do very well with ipi-nivo as a single agent. For patients that have more disease than that, you may treat them with targeted therapy first, reduce the bulk of disease, and then because of the DREAMseq data, you may want to probably switch them to immunotherapy sooner rather than later. You don't really want to keep them on targeted therapy until they recur, because we know that cohort in the DREAMseq trial did not do as well. Another option, if depending on the number of these lesions, you may resect them or excise them and then give them immunotherapy at that point. Okay. And in terms of adjuvant therapy, we have two options, right? We have two approved options for patients that are BRAF mutated. They either get adjuvant immunotherapy or they get adjuvant targeted therapy. So both have advantages and disadvantages. Targeted therapy has advantage of having reversible side effects. Immunotherapy has, some of these patients may have side effects that are irreversible, particularly the endocrine immune-related events. Those are irreversible. On the other hand, targeted therapy is more toxic and sometimes more difficult to give to patients in the adjuvant setting. You have to do frequent dose adjustments, but I think you really have to individualize.
Well, thank you very much. We have lunch. I encourage everybody to bring lunch. We have a presentation during lunch hour. You can take lunch on your own or you can bring it in and attend the online presentation. Thank you.